I'll be dealing about the basics of coronary physiology. Human coronary artery system consists of the epicardial coronary arteries, which are a three-layered structure, which are mainly condy vessels, and they offer minimum resistance to flow, the so-called epicardial coronary arteries, or the level 1 of resistance. Next, we have the pre-arterioles and the arterioles, which are sized between 400 to 40 microns, that offer the bulk of resistance. They act as sort of gatekeepers, which regulate the coronary myocardial blood flow and keep it at a constant rate depending on the metabolic demands, or the level 2 of resistance. Finally, we have the capillaries, which are basically the exchange vessels where the exchange of oxygen and other nutrients takes place. So this is the third level of resistance. Now, how does the coronary physiology work? In a normal coronary artery without any stenosis, the coronary perfusion pressure is the aortic pressure. R1, or the first level of resistance, is minimal. At the second level is the resistance where it happens and it is normal and the resting flow is maintained. When this coronary artery picks up a block or a stenosis, there is a decrease in the perfusion pressure, as can be seen, and as can be seen here, the level 2 of resistance decreases, and that helps to maintain the coronary blood flow. When the same coronary artery is subjected to stress, in the absence of stenosis, the arterioles can dilate and the coronary flow can increase proportionately. Whereas, once you have a stenosis, the arterioles are already dilated and further dilatation is not much possible, and so the stress-related flow doesn't improve or increase as much. Or in other words, there is a decrease in perfusion with stress in a coronary artery with stenosis. Looking at it another angle, you can see that the resting flow is maintained till the stenosis severity is approximately 50% in the resting stage. When you put the patient to stress or the person to stress, there is a maximum flow happening in the absence of stenosis, but as the stenosis severity increases and goes beyond 50%, the coronary flow decreases substantially, and that gives rise to symptoms. So this is the basic of coronary circulation or coronary physiology. And we have been attempting to measure this with very different modalities, and FFR has stood the test of time. In fact, FFR over 16 years had 3 different conceptual models, but that one that has stood the test of time is the one proposed by Nicopigelis, and which is the one that we use in the recent times. So the true definition of fractional flow reserve is the maximum achievable blood flow in the stenotic coronary artery divided by the maximum blood flow in the same artery without stenosis. There are 2 terms that are of most importance. One is maximum and 2 is flow. Although in clinical practice we measure or we know fractional flow reserve as the ratio of the pressure distal to stenosis and that proximal to the stenosis, it's actually a measure of flow. How flow can be equated to stenosis we will see in the subsequent slides, but the more important word here is maximum. For youngsters attending this, there is nothing called baseline FFR. Even if you get a low PD by PA after putting the pressure wire, you still need to give hyperemia to tell that you have measured the FFR. Coming back to the concept of autoregulation, as I told you before, this level 2 of resistance actually maintains the blood flow at a constant rate depending on the metabolic demand. The concept of FFR demands that once you knock off this resistance, then the relationship between pressure and flow is linear. Although this may be an oversimplification, that is the practical aspect of that's the most practical equation to that. So the flows can be equated as to pressures by applying the principle of Ohm's law. Since flow is the ratio of the pressure difference across the coronary system divided by the resistance, Q can be substituted by the pressure difference divided by resistance. Since resistances and the venous pressures are minimal, they can be considered negligible, and finally we arrive at the equation of PD by PA. This concept was put to test in 45 consecutive patients by Nicopigelis himself, and he found that all 21 of his patients who had all the 3 stress tests, that is the exercise bicycle test, the thallium scintigraphy or dobutamine stress test, had an FFR value of less than 0.75, or they had evidence of inducible ischemia by one of the non-invasive tests if the FFR value was less than 0.75. and none of the patients who had an FFR value of more than 0.75 required a revascularization in the subsequent 14 months. That's how this ischemic cutoff threshold of FFR came into vogue. FFR is now been measured for over 3 decades now. The evolution of the FFR console has taken place. RADI has been in the forefront to develop the systems. This is the first console that we had it available in India, roughly in 2006, 2007. And now we have the Quinten system, which is much like an iPad. The pressure wire technology has also evolved over the years. From the first pressure wire that was made on the kitchen table of the Nicopigelis family, where a stripped balloon catheter or over-the-wire balloon catheter was used to measure the FFR. Now we have the piezoelectric systems, the microcatheter-based systems, as well as the optical fiber technology, all of which by different vendors that can measure the FFR. But still, the adoption of FFR has been low. If you look at this 2016 slide, in most parts of our planet, the adoption of FFR is less than 5%. Yes, you know the answer, the cumbersome process of giving adenosine. And that has limited the adaptability of FFR despite robust evidence for its use. So people started to look at measures to measure the coronary physiology in the absence of FFR, and thus the concept of IFR was born. This is from the PhD work of Dr. Sayan Sen, where he identified a period in diastole which he named as the wave-free period, where the flows are higher, the resistances are minimal, and stable, and the gradient is bigger. And you measure the PD by PA in that wave-free period and termed it as IFR. That's how the resting pressure indices came into vogue. Soon it became clear that there is no significant difference between the non-hyperemic pressure ratios, provided you use the right software depending on the definition of the non-hyperemic pressure ratio. All of them have the same cutoff value of 0.89. So we now have two cutoffs, 0.8 and 0.89. And we have the gray zone of 0.75 to 0.8 for FFR, and for the non-hyperemic pressure ratios, probably 0.86 to 0.93. But we must understand that although these are the cutoff points that we use in clinical trials, the observed value in clinical practice, the observed value in large-scale clinical trials is somewhat actually quite smaller. Or in other words, the level at which the FFR has been shown to be benefit is at a much lower level than the contemporary values in use. Now, that brings us to the concept of ischemic continuum, which is the very basic of measurement of FFR. As can be seen, when the FFR value dips from 1 to below down, say to 0.7 and 0.8, the MACE values on the right actually keep on increasing, with the steepest rise occurring at somewhere in the FFR value of 0.8 to 0.6. It's in these patients with the lowest FFR who are at a high risk of subsequent event rate where a PCI benefits over a medically treatment group. As the FFR value increases, you can see that the curves of the medically treated group and the revascularized group keeps converging, and at a point which we believe and practice as the gray zone, the curves diverge again, and at least beyond this point that PCI probably increases the events or is not beneficial. So what is it that when you have a value or you have measured the FFR in the best possible way and you have a value at hand, what does that mean? What does that mean to the patient? What does that value of say 0.7 or 0.8 mean to the patient? It means that at that value, ischemia exists not as a dichotomous state, but rather as a graded continuum. That value should be used as an objective tool to personalize the risk-benefit trade-offs continuously instead of a binary fashion. And greater absolute value of any physiological modality is obtained at more severe or lower FFR values. So this must be kept in mind when we measure the FFR. We have evidence still accumulating. If you search for the PubMed for coronary vascular physiology in humans, you get 130,000 papers, almost 7,000 publications per year. And now we have the concept of ischemia and non-obstructive coronary artery disease as well. We'll be hearing from the chairman himself regarding the concept of INOCA, microvascular angina, vasospastic angina, etc. And we have measures, not only to measure the epicardial vasculature like FFR, but also the coronary microvasculature as well. So in conclusion, Mr. Chairman, ladies and gentlemen, there are present-day coronary physiology, it's just like an a la carte menu in the restaurant. You are presented with a bunch of opportunities. you can either go for a CT-derived FFR, which is coming up in a big way, or an angiographic-derived FFR, which is like QFR, which is also coming up. But the wire-based technologies or wire-based measures of coronary physiology are there to stay, and they are now well established. It may be a hyperemic pressure ratio or a non-hyperemic pressure ratio. And I'm sure that this conference will look into the nuances as well as the intricacies of each of these measurements in detail in the coming hours. Thank you.